Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckville and I will be serving as your program facilitator and will present your questions to our experts to talk about the latest medical and surgical treatment options for hip and knee pain. Well, thank you so much for submitting your questions in advance of tonight. And the questions that you'll hear me asking the providers are all submitted right from when you registered for this webinar. If you have any questions throughout our discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you should see an icon that says Q&A. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event. And due to hospital university guidelines and privacy, we are unable to comment on specific cases. Well, with that, I want to go ahead and introduce our experts for the evening, starting with Dr. John Petalillo with hip and knee orthopedic surgery and Dr. Andrew Starr with hip and knee orthopedic surgery. Well, thank you both for joining us. And before we dive into our questions, I'll give each of you a minute or two to say hello and just provide a little bit of background information about yourself. So Dr. Petalillo, let's go ahead and start with you. How are you doing this evening?
I'm doing great, Sarah. Thank you. It's great to be with you tonight and to be with everyone who is on this webinar. I'm in practice at Jefferson 3B Orthopedics. We're located in Langhorne, Pennsylvania at the Jefferson Bucks Hospital. I practice primarily total hip and total knee arthroplasty or replacement surgery, but we also treat patients non-operatively for knee and hip arthritis as well. I've been in practice in the Bucks County area for approximately 25 years.
Okay, well, thank you so much for joining us and excited for our discussion tonight. Dr. Starr, how are you doing?
I'm doing great, Sarah. Thank you very much for having me.
Absolutely. Go ahead and provide a little background information about yourself.
Okay, sure. Well, I've been around a long time. I've been practicing in this location in the Abington, Willow Grove, Doylestown, some in the Northeast for about 36 years. My practice is 100% limited to joint replacement surgery. I see a lot of folks with joint replacements. I'm also responsible for a number of the programs at our hospital, our hip and knee program, our spine program. I administrate that. I deal with patients, families, and my particular interest is in technology, things like robotics and navigation and other ways to do a knee replacement better. So it's fantastic to be here. It's always fun to talk about this. For me, this has been a broadening experience to get involved in all of this technology. And it's really fun to talk about it with patients one-on-one, but also in an environment like this. So once again, thanks everybody and welcome to our program, and I hope you enjoy it.
Yes, absolutely. Welcome. Well, thank you both. And I know, like you said, we're going to get into a really great discussion tonight. We received a lot of questions ahead of time. So thank you all who submitted. But without further ado, let's dive into it. And question number one, Dr. Petalillo, this one is for you. Can you talk about the differences between partial and full knee and hip replacements?
Sure. There are differences in types of joint replacements. By far, the most common procedures we perform are total joint replacements. In the knee, that would be replacing the end of the femur or thigh bone, and also the top of the tibia or shin bone, and the underside of the kneecap or the patella. In the hip, it would be replacing the ball and the socket joint, which is the femur and the acetabulum. They're the most common procedures we perform because generally patients have multi-compartmental disease, meaning their arthritis isn't really located in just one specific compartment. It's usually all over the joint. So the total joint replacement is by far the most common. But in terms of knee arthritis, sometimes people have isolated arthritis, meaning two of the three compartments may be preserved and they may have advanced compartment arthritis on the inside or under the kneecap. And in that case, a partial knee replacement may be the best option for that patient. Now, in terms of hip replacement, by far, total hip replacement is the most common. And sometimes we do partial hip replacements, but that's usually in the setting of an elderly patient who is a low demand patient who sustains a fracture and we may do what's called a hemiarthroplasty or a partial hip replacement in that case. But even in the case of fracture, when a patient is relatively active and vibrant, we would opt to do a total joint replacement or total hip arthroplasty in that case, because that will give that patient the best outcome in terms of function and durability.
Okay. Well, thank you for walking us through it. Really helpful. All right. Next question here, Dr. Starr. Who is a good candidate for knee and hip surgeries? And are there age or weight limitations?
Sure, thank you. So candidates for knee and hip surgeries, that's something that I think probably John and I spend a lot of time talking to people about in the office, because the candidates for knee and hips replacement surgery, it's not like you have a broken leg and you say, oh my God, how are you going to walk on this? We better do something right away. In 35 years, 36 years, tens of thousands of these procedures, I don't think I've ever done an emergency knee or hip surgery. So the first thing to understand, and I think we're going to talk about that tonight, the two of us, how we do, what other treatments are available, what sort of things should you be thinking about. But this is a very long, this is a long part of the discussion that I have with every patient in the office. So a couple things, and I think we'll probably touch on this as we go through other questions. But number one, I always tell patients there's three things you can do when you have knee or hip arthritis. One is you can ignore it. What's the number one treatment for arthritis? It's to ignore it. Most people, oh, my thumb is a little sore, my neck's a little sore. It's an aging thing, which I'm all too familiar with. And so we can just sort of ignore it, maybe take an Advil every so often, use a heating pad. Then you get into what I call non-operative treatments, or what we can commonly deal with. So that's things like injections, physical therapy, braces, canes, medications, weight loss, chiropractic can be helpful, acupuncture, massage therapy, and that list goes on and on. And basically, those are not things that change the arthritis. They treat the symptoms. And then finally, you get into procedures that can change what's going on in your knee. And some of those are restoration procedures where you might try to rebuild cartilage or graft or do something like that, like in a younger patient. And then the others are the arthroplasties, where we put in what you could commonly call a knee or hip replacement. We're using a metal and plastic knee or hip in most cases to give you a brand new joint. So without dominating this whole conversation, because I think the two of us could probably answer that one question for the next hour and a half. I think that's a good overview. There's no age or weight limitations. I think we're going to probably get to that in some other questions. So I think I'll leave that on the table. But suffice it to say that a knee or hip replacement is meant for somebody who's having significant quality of life issues, and for whom a surgeon says that they're a good medical and surgical candidate. And so I think in a nutshell, that's what you want to be looking for. And if you go see your doctor and they just tell you what to do, that's not how I think most of us like to work. What we want to do is get the patient involved. I can tell you there's two things that we talk about every time. Am I able to tell you that you're a medical or surgical candidate, number one? And number two, do you want to have surgery because of your quality of life? So I think I'll leave it at that to not get to be too long on that.
Okay, thank you. Yeah, I think that quality of life is a really important distinction. So appreciate it. Okay, next question here, going back to Dr. Petilillo. What is the average time a hip or knee replacement lasts? Are surgeries needed for upkeep?
So that's an interesting question. I don't think we can speak to an average time that knee or hip replacements last. Early in my training, we used to say, it's going to last 10 years. But we know now that the joints we're putting in now, I think we generally tell patients that you can expect that this joint's going to last 20 years or longer, because really the techniques have gotten better over the years, and the surgeons have actually gotten better in putting these components in, and generally they tend to last longer. Certainly the younger a patient is when they get their first joint replacement, the more likely it is they're going to have more surgery in their lifetime. And that's simply because, unfortunately or fortunately, they're probably going to outlive their joint replacement. So the younger they are, the higher the risk of a revision surgery sometime in their lifetime. And usually the younger patients are more active, and sometimes they put more stress on the joint replacement that over time could cause it to fail a little sooner than normal. But I can tell you that the joints we're putting in now, I think we generally tell people they should last 20 years or longer. I've seen some joints in 35 plus years. And this is with technology that's nowhere near as good as what we're using today. And they were put in, more than 30 years ago. And surprisingly, they lasted a very long time. So it really depends on, the age of the patient and the activity level that they impart on their joint. But I think generally, we're telling people that it could really last decades and hopefully several decades.
Great. Well, that's promising to hear. So thanks. Okay. Dr. Starr, going back to you here, I know you mentioned earlier talking about the latest technological advances. So could you talk a little bit about robotic surgery options for hips and knees?
Sure, and obviously those are the things I was alluding to in terms of technology, that and other things. I'm going to share my screen here for just a minute, if I can, and bring up hopefully some pictures
Yeah,
of
absolutely.
what these things look like. Okay, can you see my screen?
Yes, we can.
I'm going to make it probably a little bigger here. Okay, so there's a lot of robots available. You go to the Ace Hardware store, and I'm probably advertising for Ace Hardware, which I'm not supposed to do. But you go to the Ace Hardware store, and you see all kinds of different wheelbarrows out front and different kinds of chairs. Well, there's a ton of robots, and these are just knee robots that you see in front of you. Some are big and cumbersome, although they work very well. Some are very small. You see the blue one that's toward the front. I don't know if you can see my pointer, but the blue one that's toward the front, it's simply a device that looks at the knee. And if you get in the wrong spot in terms of your cuts in the bone, it goes away. It stops. It pulls the cutting device away. And there's plenty that work in different ways. The one I use the most, which is for knees, is one that has a robot guided saw. So basically what you see in front of you is there's a saw, but it's captured by the robotic arm. And these are two different companies that provide a similar device. And we can literally make very accurate cuts. So it converts us from a ruler-driven procedure like we did years ago, where we just use guides or jigs and we place them on the knee, to a computer-based system where the computer looks at the knee and finds the right spot. You adjust it on a computer screen, and then it guides you there. Now, I always get asked this question: does the robot do the surgery and then the surgeon's off on the golf course? We're not quite there yet. That does not happen. Basically, everything we do has to be guided by the surgeon. We're pushing the buttons, we're moving the robot, and we're really doing the work. So that's a knee robot. There are similar robots for hips. They all require computer guidance, and they all then have an actuator tool, whether that's a drill or a saw or a reamer or something that we can use to put the bone in the right position. This graph that you see in front of you, though, even though, this robotic technology hasn't been around for that long, probably pretty popular for the last 5 years, and been present and available probably for about 10 years. But you can see every curve here for big and small hospitals, as well as different insurances. On the left side is 2008, very, very low percentage of patients having surgery with technology. By 2015, it's up close to 12%. And right now it's probably close to 25 or 30%. So a lot of surgeons are adopting this because I think they just quite frankly think that that's going to be the future, and it's going to be more accurate, and hopefully we're going to do a better job. So I'm going to unshare my screen, and thank you for asking that question.
Yeah, absolutely. And thank you for walking us through those slides. It's really helpful to see those pictured. So appreciate it. Okay. Well, going along those lines, Dr. Petalillo, can you talk to us about what the recovery time might look like for these types of surgeries?
Sure. Recovery is an interesting term because we can define it a couple different ways. If we're talking recovery, meaning better than you were before the surgery versus as good as you're going to be. Now, a lot of these patients, by the time we actually perform surgery on them and do these joint replacements, are very in a great deal of pain, severe pain. A lot of their function is very limited. Some people can hardly walk even a block. So in terms of better than they were, a lot of these patients are better than they were within hours of what we do, especially patients with bad hip arthritis. We perform these surgeries, we see them, a few hours later. They typically go home the same day, but before they leave, they can tell that the pain they're in or whatever discomfort they're feeling, maybe incisional pain or what have you, it's different than what they had. So right from the beginning, they're already starting out better than they were. In terms of as good as they're going to get, certainly most of the patients that we're doing, I think the majority of them go home the same day now, which is a great difference compared to many, many years ago. They're walking same day, going up and down stairs the same day. By 2 weeks, most people aren't really using any assistive devices like a walker or cane at that point. And typically by 6 weeks, most people are getting around very, very well. Now, in terms of as good as they're going to be, by 3 months, most people are back to almost normal activities, but they can really improve incrementally up to about a year. But certainly by between 6 weeks and 12 weeks, I think patients really see the big difference and they're really starting to see what the benefit of the surgery was.
Okay, thank you. Helpful to hear. All right, Dr. Starr, question for you here. What is the best way to protect your knees after knee surgery or replacement?
Well, it depends. It really depends a lot on who you're talking to. Unfortunately, orthopedic surgeons themselves don't agree. And, sometimes we see advertisements of patients, who are purported to have knee replacements or hip replacements, and they're playing basketball or playing soccer. What I would say to you is, all these implants, from the moment you put it in, it's like having a new set of tires on your car. The more miles you put on them, the more quickly you're going to wear them out. I've seen patients wear their knees out in 4 or 5 years, or as Dr. Pitalillo says, he's seen patients 25, 30 years. And obviously, we'd like people to keep them for a long time. We don't want you to wrap yourself in cotton and sit home all day. But I usually tell patients that moderate activities are going to be associated with a very long-lasting knee or hip. So that would be things like biking, hiking, swimming, going to the gym. To give you a concrete example, I like pickleball better than racquetball or handball because less cutting, less force on your knee. I tell people, I've had patients go bungee jumping and parachute jumping after their knees. One in particular broke his femur doing it. I don't think that's for you. If you want to ski, pick a day it's not too crowded and not too icy because it's the collision that's going to get you, not just gliding down the mountain. So there's a lot of common sense in this. And it's a really good conversation for the patients to have with their doctors. Sometimes they get very much into the minutia. They want to try to go over every single activity they do. But really what we want to do is try to educate you to think about it. Maybe somebody else could clean your gutters this year. I'm sure we could, share horror stories amongst orthopedic surgeons of people who've hurt themselves in ways that we just wish they hadn't. And that's true of people with or without joint replacements. But we try to give you the tools to understand that you can be very active and you can be in great shape. But what we want you to do is think about your knee before you do something. Think about your hip before you, climb up that ladder.
Absolutely a good conversation to have. Okay, well, thank you. All right, before we get into our next question, just a quick plug to feel free to submit any questions you have in the chat. I know some have already been coming through, so thank you. We will be getting to our live questions shortly. But for now, on to our next question, talking a little bit about pain management. So Dr. Petalillo, what are pain management options after surgery?
So pain management, we've made great strides in pain management. As much as we've made great strides in terms of the implants and our techniques and robotics and technology, I think one of the biggest things we've made strides in is managing the pain after surgery. Early in my career, we would admit patients for 5 or 6 days into the hospital. They would be given a morphine pump and they would hit it on demand to control their pain, high levels of narcotic medications and all the side effects associated with those. And over the years, we've really gotten into what we term as a multimodal pain management program, which means we use a variety of medications and we try to limit the use of narcotics when we can. But we use some of the over-the-counter medicines like acetaminophen. We use narcotics when we need to. We use medicines that work on different pain pathways. And we give these medicines before surgery, before they even go into the operating room. Oftentimes during the surgery, we'll give sometimes local injections to try to diminish the amount of post-operative pain that someone is going to have after the surgery. And then we give multiple different medications that really work synergistically post-operatively that actually allows them to leave the hospital the same day, whereas years ago they were in for 5 or 6 days and they were on a morphine pump for a couple of days. And so really we made great strides in that. And that really is what allows us to send patients home the same day and what allows them to get to the level of activity that they get in such a short period of time. And really, probably the biggest benefit is they don't have the side effects of a lot of the medications that we used to give them, the nausea, the vomiting from the narcotics, and all the other bad side effects. So I think that's been one of the greatest strides in joint replacement in the past 10 years.
Yeah, really interesting to hear that evolution. All right. Dr. Starr, we will go back to you now, talking a little bit here about injections. So how do they work and how are there different kinds? Can they be used in replacement of surgery or used after surgery?
Well, they're mostly used before surgery or in place of surgery. So, we offer some part of the Rothman Institute. So we have a lot of different doctors. We have doctors who simply do the more simple treatments and the straightforward office treatments, which a lot of patients are looking for. So that's things like steroid injections and predominantly the gel injections. We call it viscosupplementation. So most commonly people do steroid injections, cortisone, they call it, lidocaine, and local anesthetic with it, amongst other things. But it's basically a cocktail that you inject in the knee. It provides a certain amount of local pain relief for a few hours, and that's just to get over the shot. And then it provides reduction of inflammation. That's what steroids do, cortisones and such. And that reduces the inflammation in your knee. And there's usually an inflammatory component to the arthritis in your knee. So there's many different kinds of arthritis. We won't cover that here. But basically, so the number one thing that we do is we give a steroid injection. It's usually given as a single shot, although you can give it in a series. And patients will frequently come in for these on a schedule. So they may, if they decide they're going to treat their knee like this, they may be calling every 3 or 4 or 5 months when their knee hurts or when their hip hurts. It's harder to give one in the hip because it's a deeper injection. We usually use technology for that. So we'll use X-ray or we'll use an ultrasound, much like pregnant women use to see their babies. So we can get it in the right place. We usually don't need that for the knee. So number one is the steroid injections. Now they've gotten a little bit of a bad rap. I don't treat young people with sports injuries. I just take care of people with arthritis. So I'm very liberal with the use of cortisone. The side effect of it can be advancing your arthritis, but if you already have arthritis and if the alternative is a joint replacement, then you're going to be helping yourself by avoiding that surgery or putting it off, particularly if you're young. So by all means, I would go ahead and have a cortisone shot. Viscosupplementation is a little different thing. It's been around for a long time. I'm not sure we 100% understand how it works or even if it works. It's a thickening agent called hyaluronic acid that occurs naturally in cartilage. It looks like a clear jelly, and you inject it in the joint most commonly once a week for 3 weeks, but there's different ways to do it. And it's meant to beef up the lubrication in the joint. I'm not sure that we understand, as I said, exactly how it works. I would say in my hands, most people get at least some relief with cortisone. Their complaint is it may not last long. It may last 2 days or it may last 6 months. The viscosupplementation is designed so it's supposed to last 6 months. I would say the success rate's a little lower, but for those patients who are trying to avoid surgery, it can be an option. And both of these options, unlike some of the other injections that we may get to in further segments, are generally covered all or in part by your insurance company.
Okay. And out of the injections that you just walked us through, so PRP, the traditional steroid injections, and the visco supplementation, do you have an opinion between one over the other? Oh, we may have lost Dr. Starr there. Okay. Well, we'll see if he.
Let me pick up on that question
Please.
while we're having a little technical issue there. I think all these injections are part of the armamentarium that we can use to treat patients. Not unlike anti-inflammatory medications, physical therapy, other things we're going to talk about a little later, but it's something else in the toolbox that we can use to treat patients. And I think patients generally would like to try things before surgery, so that usually includes some type of injection. And it's really hard to say what kind of relief any given patient is going to get from an injection, because I've had patients over the years who get great relief for many months after, say, a steroid injection. And I have some patients who, despite an x-ray that doesn't look all that severe, maybe doesn't get that kind of relief at all. So I make all these injections options for patients. Steroid injections, lubricant injections, which we call the visco supplementation. We usually start with the steroid injections first, because sometimes maybe one injection of a steroid is all somebody may really need. But if it's a recurring problem and it just doesn't really get better, then I think the other injection options are just that, an option. And if it works, great. And if it doesn't, at least the patient knows in their own mind that they've tried virtually everything they can do prior to moving forward with surgery.
Absolutely. And like you said, just great to know that you have options available.
Absolutely.
Okay. Great. Okay, so our next question here, is there any news on stimulating cartilage on worn down cartilage?
So in terms of stimulating cartilage, so there are some techniques that are out there for regrowing cartilage or healing cartilage. But generally, that's not in the setting of the patients, the older patients that we're treating with the arthritis, because arthritis is really a widespread type of problem that affects a large portion of the joint, if not all of the joint. Some of our sports medicine colleagues do procedures where they harvest some cartilage cells, they grow them in a lab, and then they're able to go in and implant them. But usually that's only to fix small defects. Meaning, if you think of a road, like your road outside of your home or a road in your town, if you have a well-paved road, but there's a pothole there, but the rest of the road is really good, you can fill the pothole, and then, that's a good road again. And that's very similar to, say, a younger athlete who has pretty normal cartilage, but maybe due to an accident or an injury, they have an area where the cartilage is damaged. So techniques are out there that may be able to stimulate new cartilage and cover that defect. In terms of the patients that I and Dr. Starr see on a regular basis, those roads don't need pothole fixing, they need to be repaved. So basically, the entire road needs to be redone. So, growing cartilage for such a big area is really not an option. So there really are new techniques for patients who really have degenerative arthritis to regrow cartilage. Now, with that said, there are some newer technologies that we're going to touch on a little later, stem cells and things like that, that may show some promise in the future. But as it is now, there are no technologies to regrow cartilage in arthritic knees.
Okay. Interesting. Yeah, and I really like that road analogy. That paints a picture very well. Okay. Well, Dr. Starr, you joined just in time. Our next question here is talking a little bit about those new technologies on the horizon. So do you mind just kind of diving into that a little bit more?
Well, there's a ton of technologies that are out there, that people talk about, and it's everything from different kinds of injections whether stem cells, I don't know if I had a little power interruption, so I don't know if during that you discussed that. But, there's injections that may be new technologies that we don't do very well yet, but that we need to refine and find ways to grow new cartilage. There's everything from that to just doing a better joint replacement. I think a substantial part of the focus right now has been in things like artificial intelligence, combining some sort of robotic technology, like either a robot in the operating room or some sort of computer assistance, and then following that into the outpatient arena. So when you leave the hospital, you can continue to provide updates, and ultimately artificial intelligence will combine all that information and tell me as a surgeon, well, when you put this knee in a little looser, on average, patients who are 5 foot tall and have beards seem to do better if they're a little looser, and patients who are tall and thin and come from Nebraska seem to do better when it's tighter. And that we really need to get down to that degree of detail in how we do our surgeries. So we are now in the period, and I showed you some of the technologies for knees and similar for hips, where we can really do things very precisely in the operating room. Thus far, a lot of the studies don't show that we're doing better at that, meaning maybe we do a little better, we make nicer x-rays, and the alignment's better, and maybe the knees last a little longer, or the hips last a little longer, or they don't dislocate. But we really want to take that, in the case of hips, maybe 5% of patients that are dissatisfied. In the case of knees, maybe 15% that are dissatisfied, and make them very happy with their knee or the hip. And if we're able to do that, we have the avoidance of the surgery by things like stem cells, which are not perfected yet, in my opinion. And that's why your insurance doesn't cover them. And we have things like robotics and navigation, which use computers to do a surgery more accurately, but we don't know how to set the computers. We have all these theories. I can talk to you about, how we used to take a knee and make it straight. But if you look around, people don't generally have straight knees. So we've learned, don't make the knee straight, adjust it so that it matches the muscles and the soft tissues. And hopefully we're going to show on the downstream side that that's better. But, and I think the key point is, we need things like artificial intelligence and computer simulations and machine learning so that the computers can tell us how to be better when we're in the operating room. And also, when Dr. Petillo and I are doing the prescription for you after surgery, when should you start therapy? How much bending should you do? How aggressive should you be with your activities? We need to take all of this data. And for that means that you as the patient, you need to become part of the system. So you need to be willing to put in information, tell us how you're doing, complete surveys, maybe take pictures of your joints so we can see how they're moving at any given time. Crunch all that information. And of course, we want to do that with tremendous privacy, as we've learned through HIPAA, and we have to really respect that. But ultimately, and you can see I'm getting excited about this, this is how we become better. This is how, systems like the Jefferson Health System and in my case, the Rothman Institute, want to show patients that we can do better, because we look at a comprehensive approach from the beginning when you come in, and maybe all you need is a little exercise and maybe a soft support, all the way up to your second revision surgery where you've had a knee for 30 or 40 years and we have to redo it and we want to give you an outstanding result. So that was hopefully a very simple answer, right? Sounds very simple, right? It's going to only take $1 billion in however many years. But I think it's the answer for the future. And obviously, I'm excited about it.
Absolutely. It's certainly exciting to hear, and just interesting to hear how AI fits into it, because I know for me, when I hear AI, I don't think about this conversation, but yeah, really interesting to talk about the future. Okay.
Yeah, I would echo Dr. Starr's comments about that. It's an exciting time in medicine in general, but specifically orthopedics, with all the new technologies. And he's been doing it for 30 plus years. I've been doing it for 25 years, and you can tell we're still very excited about what we do, because it's really changing. It's ever changing. We're not bored with what we do. It's the technology keeps it exciting, and we're always looking to make it better and give patients a better outcome.
And we
Absolutely.
can't stay the same, because if we stay the same, we just don't get better. Maybe technically we get a little better as the years go by, but staying the same, doing what we always did, is not an option. And you can see that across the board at every walk of life. When I was a little kid, I went to a little hardware store. It was open from 10 to 5 weekdays and 10 to noon on Saturdays, and that's it. Well, now we have, places that are open 24 hours and are huge stores. Is that better, worse? Well, ultimately, you hope it's going to be better.
Absolutely. It's an interesting conversation, but certainly exciting on this front. So thank you. Okay, well, one last question before we dive into the live questions from the audience. And thank you again. I see a lot of questions coming through, so we appreciate it. So our last question here, Dr. Petalillo, what other treatment options are there prior to surgery?
Sure, we talked about a lot of them already, but there are a lot of treatment options that people can explore prior to surgery. And a lot of these treatments people try before they even get to our office. They may take over-the-counter analgesics like Tylenol or Aleve or Advil. They may do certain topical treatments. They may take some supplements. So certainly most of the patients, by the time they get to see me or Dr. Starr, have already tried a lot of these things. And then the next line would be prescription anti-inflammatory medications. And there's a whole host of different ones. And sometimes we try a few different ones on different people because what works on you may not work the same on me. And we may have to try a couple different ones to see what works best. And then we touched on the injection. Certainly the corticosteroid injections, the viscosupplementation injections are an option. In terms of the mechanics of the knee, oftentimes we send people to physical therapy. We try to make the surrounding musculature stronger that better supports the knee. A lot of times that will reduce symptoms, take some of the stress off the different parts of the knee, and patients will get pain relief that way. And that's basically the non-operative treatment options prior to surgery.
Okay. All right. Well, thank you for detailing that out for us. Very helpful. With that, let's go ahead and just dive into the questions. So I'll go ahead and read them off, and whoever wants to jump in, feel free. So for this first question here, going back to the age question that I know we address at the top of the call, is there an upper age limit for hip replacement for an otherwise healthy patient?
I'll let Andy speak first, and then I'll follow up after his.
Okay, that sounds fine. Well, my youngest patient I ever did was a replacement on was 21, and my oldest patient was 98. So, it's not the age of the patient, it's the health of the patient, but it's also their situation, and this is the part that we talk about, artificial intelligence and robots and computers, and it starts to sound impersonal. That's not how we want to use it. Because right now, we still, and we should still always be people and be doctors. And so we have to look at every patient as an individual. So believe me, not every 98-year-old person should have their knee replaced or their hip replaced, even if they have arthritis. And not every 21-year-old should. But we have to use our judgment and also work collegially with the patient. Talk to the patient, get a sense of their needs, talk to their families. I like it when the families come in, because a lot of times the patients will say, well, I don't need this surgery. And, the daughter will say, Mom, what are you talking about? You can't walk into the dining room to have a little dinner with us. So there is no clear indication of age in surgery. It's really a lot of different points that we put together, that we look at overall health, we look at support systems, we look at degree of disability, we look at the amount of pain, we look at how difficult the surgery is going to be, other medical problems, the condition of the leg. And you can imagine, once again, we could have an hour conversation just about all the little parts to making that decision. But, our job, you're looking at surgeons who have over, 60 years of experience between the two of us. What you're seeing us for is our surgical expertise, but just as important, our ability to sit with you in the office and try to meet your needs. Number one, make you understand what the options are and what the differences are, and let you know what you're getting yourself into. Because, a person may decide to have I always use the same example. If you're 80 years old, you may look at a knee replacement and say, I'm not really interested in that. I don't want to go through all of that. Thank you for explaining it all to me. But I understand now what it is, and I really don't think at my age I want to do that. And then the next patient, you walk into the room 10 feet away, and they say, look, I'm 80 years old. I don't know if I'm going to live 5, 10, or 15 years, but I don't want to live like this. It's too much of a limitation for me. I know there's some risk involved. I know it's going to be hard work, but I want to do this because I want to do it for myself. So those are the same patient. It couldn't be more different. So unfortunately, there's no simple rules, but honestly, that's what makes me want to go to work in the morning, because that's what I can bring to the table to help a patient to make that decision. It's not just cut and dry. Thank you for that question.
Yeah, absolutely. And Dr. Petalillo, anything you'd like to add there?
Sure, I agree totally with Dr. Starr's comments. We really educate people every day. So it's really a shared decision-making process. When we sit down with the patient, again, when the family members are there, it's very helpful as well. And you're trying to gauge what they're looking for, what would give them the best outcome, whether it's more function, less pain, and we educate people every day. And at the end of the day, we like to think that they're armed with enough information to make a decision. And ultimately, again, it really depends on what their goals are. But I've done patients as young as 19, with juvenile rheumatoid arthritis, which was the best option for that patient at that time. And I've done patient 96. So really, there's no chronologic cutoff. It really depends on what patients' goals are and what they're looking to gain. And I think the best thing we can do is educate them to make the best decision.
Okay, thank you both. All right, our next question here, this one's a little bit more specific. This person is wondering, when is it safe for a patient with a knee replacement to drive a car, specifically with the right knee replacement? Any comments here?
So I can tell you what I generally advise patients. So when it's your right knee, obviously that's the knee that you need to operate the gas and the brake, and you have to have a certain amount of strength and reaction time to be able to react to whatever happens on the road. So it really comes down to function. It comes down to their range of motion. It comes down to their strength. Generally, sometimes it's at least between 2 to 4 weeks at least when it's your right leg, and oftentimes in the older patients, it's probably closer to at least 4 weeks when they're strong enough and they have enough confidence and range of motion to really operate the gas and the brake. Sometimes when it's a left knee, I'll let patients drive a little quicker, because generally my patients aren't driving manual transmissions at that age. So they generally, once they can get in and out of the car comfortably and it's their left knee, I'll let them drive sometimes as quickly as 2 weeks.
Okay, thank you. All right, next question here. Do you recommend getting both knees repaired at the same time?
Yeah, that's a tough and interesting question. Once again, it's one of those questions that I think we sort of like. Depends why they want to do two at once and whether they're up for it. I mean, this is very much like the discussion, and it's part and parcel of the discussion we have with patients about surgery. Are you the right patient for surgery, and are you the right patient to do two at once? I do a large amount of double knees and double hips, but it's easier to agree to it in a 50-year-old who's in excellent health and has a job and wants to get back to work and only wants to take off once. But it can be a pretty tough experience. So, I generally avoid people over 80. I avoid people who have a lot of health problems. And I basically look at them and say, if you've got a couple of percent or 3% risk of complications from a typical operation, a knee or hip replacement, and then you add on maybe diabetes or obesity or heart disease, and then you throw in doing two knees at once, a longer surgery, greater risk of blood loss, greater risk of transfusions, you're stacking up these risks. At a certain point, the patient has to start to say to themselves, you know what, I don't want to put that much risk to having a serious complication or to my life to have both knees done at once, which is a convenience. So a big part of this is that conversation, which I think you're hearing a lot from the two of us tonight. We need to help advise you. We're not going to make the decision for you. There's patients where I will say are a definite no. There's patients where I might suggest it as a possibility. But I would say the vast majority of patients, once they hear about what it's like to have a replacement, and it's quite opposite for hips and knees. Knees are a little rough. You have to have surgery, you have to do therapy, you have to work at it. You can do very well at any age, but it's a little bit of work. In fact, I find my older patients do better than my younger patients because I just think they're tougher. But we can talk about that offline. But the fact is that, it is a big deal. Hip replacements, with the way we do hips now, at least from what I see, the patients get better so quickly that it may be simpler to do one at a time. So, for different reasons, this is what you have to do. If you go into a surgeon and they don't really spend time with you and you don't feel like you're getting that information, or they're just not the type of person that you want to work with, it doesn't make them bad. Some people want someone who's very directive. They tell you what to do. Some people are more comfortable having kind of a conversation. Does the surgeon like you to go look on the internet? I love all that stuff. So I rather have the conversation, but somebody might say about me, he didn't tell me what to do, right? Find the person that you can work with, like their style. Everybody likes a different kind of style. It's like picking a friend or an acquaintance and someone you want to hang out with. But it's very important, and have these conversations. So once again, none of these things is cut and dried. And I think, like I said, all through this conference tonight, you've heard from the two of us really the same story. Go in, talk to your surgeon, make sure that they acknowledge that there's other treatments that aren't surgery. Make sure they explain things. Make sure they give you what you want.
Absolutely. Be your own best self advocate. So I think that's something to take
One,
away from today.
yeah, 100%.
Yeah. Okay. All right. Next question here, talking a little bit about weight. How much does weight loss impact the hip joint pain? Could it eliminate the need for surgery?
So weight is a big factor in terms of patients' symptoms if they have arthritis to begin with. So if they have symptomatic hip or knee arthritis, certainly if you're carrying excess weight, that's a bigger stress on your joint. And generally, symptoms increase when people carry more weight. So certainly goals to lose weight, get your weight down, certainly helps impact how your joint feels if it is arthritic to begin with. And if it comes to the time when we're talking about surgery, we try to get patients to optimize patients before surgery, meaning we try to get them as good as they can be, because ultimately, despite the fact that patients are in a lot of pain and they really need to have these surgeries, these are ultimately elective surgeries, even though they're very necessary. So we try to optimize patients before surgery. And that's a whole host of things that we, as orthopedic surgeons, years ago never really touched on. Trying to manage patients, not that we manage them, but we're cognizant of patients' medical problems, if they have diabetes, if they're obese, all the different things that may impact their outcome from surgery. And one of the things we try to optimize is weight, because if we can get their weight down to a more manageable degree, number one, that helps lessen their symptoms preoperatively, but it also helps postoperatively with making the recovery a lot easier generally. And sometimes it also helps to lower the chance of getting some of the bad complications that potentially could ruin an otherwise perfectly done surgery, such as an infection or blood clots or wound healing problems, things like that. So to answer your question, it certainly affects how patients feel in terms of hip and knee arthritis before surgery. And it also, if they can optimize their weight, it also makes their recovery easier and better after surgery.
Okay. And a follow-up question to that, this one's a little bit more specific, but along the same lines. This person is wondering, is there a weight limit for a joint replacement surgery? And what is the BMI that you consider for joint replacement surgery? So for knee and hip, obviously.
So I'll answer to begin with. I don't think there's a strict weight limit. It really depends on the surgeon's preference and what they feel is going to give the patient the best outcome. Certainly, it goes back to optimizing patients and looking at the entire patient, the whole patient. So it's not just the weight. Sometimes it's the underlying medical problems and the other things that may have an effect on whether to proceed with surgery. But I don't think there's a strict weight criteria. But I think we try to do optimized patients to try to get their weight, generally as low as possible and try to maximize their outcome from surgery without having a potential complication.
Okay, great. Thank you. All right, next question here. Are platelet-rich plasma injections provided in either of your practices?
So platelet-rich plasma is a part of blood where you spin down the blood and you take a certain portion of it, and it's supposed to stimulate healing within the joint. We definitely do it. I'm not a huge advocate of it. It's a little more popular for soft tissue problems than for arthritis. There are some studies. You can always find studies. There's some that go each way. Some say good, some say not so good. The insurance companies have basically said they're not going to pay for it because there's not enough information that suggests that it's that reliable. Physicians are allowed to do it because it's not a device, it's a treatment. So it's much like, putting on a Band-Aid or cleaning up an incision or putting stitches in. The FDA does not regulate that. So as a result, surgeons are sort of, and any physician is free to make a decision that they feel is best for their patient, which is a nice thing, but it also generates a fair amount of expense. And if you look across the Delaware Valley, the cost of these injections is high. I've not seen great success with it. I tend to be very upfront with patients. We do offer it. I don't do it myself. And if a patient wants it, we make it available. I think that's what a lot of offices do. But I would say to most patients that I haven't seen great results with it. And you have to look at the cost and ask yourself if you're willing to undergo that. It is a very low risk procedure, and it's not a terribly painful procedure. So from that standpoint, there's not a huge downside other than the cost. So I don't know if that's helpful to people, but I think that it's a way of at least approaching it.
Yeah,
I would,
no,
I would
absolutely.
agree with Dr. Starr as well. We offer it in our practice as well. I haven't seen great success with the types of patients that we're seeing, which are basically patients with the end stage degenerative arthritis. But certainly for some of the other soft tissue abnormalities or injuries, it has been shown to show some promise. But for arthritic hips and knees, I haven't seen great success, at least to date.
Okay.
But I think if you want to try it, it's fine. That's why I think we point out it's not a thing that you can rely upon, certainly nowhere near 100%. But if it's something that if you're the type of person that wants to try everything, I don't think it's the surgeon's responsibility or right really to tell you to do it or not to do it. And if you choose to have it and then you come back and you say, look, I tried it, it didn't work. So I think I need to have my knee or my hip replaced. That's perfectly fine. That's your decision. Hopefully you become an educated consumer. Once again, I'm big on my patients going on the internet, looking around, because if I can't answer a question that you see on the internet, then that's probably either a very unusual condition or, that you probably ought to look at another doctor.
All right. Thank you. Okay, next question here. Is it still true steroid injections cannot be given within 3 months of a scheduled knee replacement?
So generally, I think that's probably the most accepted time frame that most surgeons would allow a steroid injection to be done. Certainly, it comes down to surgeon preference, but I think we all pretty much agree that the presence of a steroid in a joint may incrementally increase somebody's chance of getting an infection after surgery. So generally, it's my practice to try to limit the injections to no more than 3 months before any type of total joint replacement surgery.
Okay.
And I think I'm gonna use a little prerogative here, just so you know, we're making some assumptions that people understand certain things. But John, you want to explain to people why orthopedic surgeons are so neurotic about infections?
Yes, because infection is one of the potential disasters that can happen after a joint replacement. These surgeries that we perform are by and large some of the most successful surgeries that are done. And the satisfaction is very, very high when it comes to patient pain relief and overall satisfaction. But these surgeries are not without risk. The chance of getting an infection is low risk, but it's not no risk. And if you do get an infection after we put all these hardware parts in there, sometimes we have to go in and take all these parts back out, and then we have to treat this infection. And sometimes it's a multi-stage operation, which will limit your ability to function in a meaningful way for many months. And you might have to get IV antibiotics for an extended period of time, most likely. And there's no guarantee that you're not going to get another infection when we get to put another joint back in. So we are a little neurotic. We're very neurotic about trying to minimize the chance of getting an infection. And if it means waiting 90 days after a steroid injection, then that's generally what we would suggest.
All right. Yeah, thank you. And appreciate you outlining that for us. Okay, next question here. How does PM&R fit in the process? I've used PT, acupuncture, and chiropractic, and PM&R is my next step before more surgical options. So any thoughts there?
Yeah, I mean, PM&R is physical medicine and rehabilitation. People call them rehab doctors most commonly. We have a number of them in our practice, and they do a lot of the things. Many surgeons do a lot of the non-operative treatments that I mentioned, those sort of middle ground treatments, injections, physical therapy, braces, canes, things like that. That's a part of our practice. But we often supplement that by, we have people who, within medicine who have an expertise at this level that they can augment what we do in those areas. So, if you have a patient who pretty much doesn't want to have surgery, or maybe they're just in the early stages where they haven't really considered going to that length, many of them may be treated by us directly as surgeons, or they may be treated by a rehab doctor. It's sort of interchangeable in the early stages. But the rehab doctors do have some other areas of expertise in things like gait analysis and rehabilitating things like strokes. They tend to work very closely with physical therapy. They do a lot of injections and things like that. So, it's part of the team. And so if somebody says, oh, you have to go to a rehab doctor, well, it depends what you're doing with your orthopedic surgeon or even your family doctor. We have a number of primary doctors who will start off with the injections and things that they're comfortable with. So it's all a part of a team approach. And that includes everything from physical therapists to nurses to, I already mentioned, acupuncture, chiropractic, massage therapy. I mean, these are all part of our armamentarium. Surgery is not the answer for every patient. We certainly do an awful lot of it, thousands of these procedures every year, but that doesn't mean that you can't get satisfaction from the milder forms of arthritis, or if your pain level's lower, with some of these other treatments. So I think a rehab doctor is a very good part of the team. And, we really like having them to work with, because they do sometimes provide that additional bandwidth, availability and being able to get to see them in the office more quickly to really help out our patients so they don't have to wait.
Okay, great. All right. Know that we're just over top of the hour, so we'll take a few more questions here and then wrap up for the evening. But one next question, this person is wondering, can you comment on lateral approach patella tendon sparing in total knee replacement?
I personally don't have experience with lateral approach total knee. Maybe Dr. Starr could speak to that if he does.
Yeah, I mean, there's a lot of ways to get into the knee. We were doing this, oh my God, 35, 40 years ago when I was a resident. There was a couple of doctors in the area who popularized this, and we did a number of cases. So, people talk about the different approaches. An approach, you really learn great things from your patient. So I always had a patient, I would talk to them about how we do a hip or how we do a knee. And I'd explain where we make the incision and how we do it. And there's all these sort of terms for it. And you may hear muscle sparing or tendon sparing or, a variety of different things. But basically the patient looked at me and said, "Oh, so you're telling me you put the same joint in, it's just how you get there." So that's a great way to think about it. So how you get to these joints really varies from surgeon to surgeon. So for example, in a hip, you can go front, side, or back. There's basically three different incisions. And we can debate the pros and cons, and that's a great thing to talk to your surgeon about. In the knee, you can do very medial, which means toward the inner part of your knee where it touches the other knee. You can do right down the center. You can do lateral. Some people have had some better success with going lateral if you have a patient who has a arthritis that's predominantly on the outside of the knee, and they're typically knock-kneed. But you're really getting sort of into I wouldn't say the weeds because these are important conversations, but we're getting into a lot of detail. And what I would say to you is, talk to your surgeon. I have experience because I've been around so long, and these have sort of come and gone with all of the above mentioned procedures. I've done every one of them. But I have my preferences. Sometimes you talk to two or three surgeons and you may get slightly different answers. Learn about it if it's something you're interested in. But lateral tendon sparing surgery, other than for people having partial knee replacements on just the outer portion of their knee, we just do half of the knee, is not that popular today. But there are still some surgeons who might consider doing it.
Okay. Helpful to hear. So thank you. Next question here also might be a little bit more specific question. This person says, I have had radiofrequency genicular ablation. It has been helpful. Do you utilize it?
So those types of procedures basically are trying to affect the nerves that carry the pain fibers, the pain signals to the patient. So in somebody who, for whatever reason, maybe is not a candidate to undergo other treatment options, such as maybe a knee replacement for whatever reason, medical reasons or otherwise, some of these procedures to affect the nerves may be helpful. I think as orthopedic surgeons, they're not procedures that we would generally do. So generally pain management doctors who specialize in different injection procedures and radiofrequency ablation procedures to affect nerves would do those types of procedures. I would say they're probably not all that common, but in somebody who would not be able to undergo the conventional type of treatment, which would ultimately be a knee replacement, then that type of procedure could be explored by patients as another option in their armamentarium to try to treat their pain. And certainly a pain management doctor would probably be the specialist to do that type of procedure for them.
Okay. All right. Thank you. Okay. One of our last questions here. This next one is talking a little bit about the different viscose supplementation gels, which I know we went into earlier during our discussion tonight, but they would like to know how many treatment cycles may be given. So could you just talk about that a little bit more?
Yeah, that's kind of it. That's fortunately an easy question. So there's the viscose supplementation products that are out there on the market, and there used to be one, and now there's literally dozens of them. And some of them are even offered in various forms, and in some cases, it's just more in the syringe, a bigger injection given once versus multiple injections. So let's break this down in a very simple way. For each treatment cycle, which would be, completing your treatment for a given length of time, usually 6 months, and that's based upon how often, in many cases, the insurance companies will pay for it, can be generally 1 injection, 3 injections, 5 injections, sometimes a few more or a few less, usually given once a week. So that's a cycle. It's almost like, I hate to use this example, but it's almost like chemotherapy. You get a cycle and then you have a break. In this case, hopefully the break means that that's a period of time you feel well. You then can have it again in 6 months. There is no limit to how frequently you can have, I'm sorry, to how many in total you can have. Meaning, if 6 months goes by and you want to do it, and I have patients we've injected in our office for over 10 years. It doesn't mean they're having it every 6 months, but it may be intermittently over those times. And honestly, it's the same for cortisone. People kind of have this notion that cortisone, steroids, same sort of variations on the theme, these anti-inflammatory injections in the knee. I space them out every 3 months. There's not any absolute, but that's a pretty common routine. And I don't want patients to get too much cortisone because it can have side effects in terms of the whole body. You can have reactions from a glandular or systemic way because of getting too frequent cortisone. So I don't want you to get a back injection and then 2 knee injections and a wrist injection. So we kind of space them out every 3 months. But patients can, many of the patients who see the rheumatologists, which by the way are arthritis specialists who don't do surgery, they're another great member of the team. They may do it for years. So, we've mentioned tonight, Dr. Pedalillo mentioned the pain management for things like the nerve blocks in the knee. There's a couple different kinds. Now we mentioned rheumatology. Mentioned rehab doctors. We haven't talked about physician assistants who can help us. Family doctors we mentioned. Internal medicine doctors. I'm probably forgetting a few. John may chime in, but we basic physical therapists, massage therapists. The teams are huge. They're not necessarily all in one office, although we have a lot of them because we have a big office. But that doesn't mean you can't get them from a single practitioner because they can refer you. So it's really, there's a lot to this. And I think, it's worth having those conversations.
Absolutely. Okay, well, thank you. And one last question here, and then I'll wrap up with my own question before we end tonight. But you mentioned physical therapy. So this last question here is, what is your opinion of physical therapy right after surgery?
So physical therapy right after surgery is something we use very frequently. I would say personally, I use it more after knee replacement than hip replacement because I think patients can do a lot of the activity after a hip replacement on their own. Basically, walking is really the best thing you can do after a hip replacement. So I generally don't send any of my patients for physical therapy after a hip replacement. I just tell them to walk. It's really the best thing they can do. In terms of the knee, sometimes, as Dr. Starr alluded to earlier, we're trying to get a certain range of motion. We want to maximize range of motion because that's going to maximize the patient's function. And some patients will need a little help with that. And that's where physical therapy comes in. And certainly we start range of motion exercises, whether it's the patient doing it on their own with an app on their phone, whether they're doing it with a home physical therapist, or they're doing it actually in a supervised physical therapy setting. The goal is the same. It's really to maximize the function. And sometimes it's often started immediately, and sometimes it goes on for several weeks, sometimes even a couple of months, as long as the patient is making progress and trying to maximize their range of motion in terms of their knee.
Okay, great. And just fitting into that big team, just as Dr. Starr alluded to earlier. So great. Okay, well, with that, I want to go ahead and ask one final question of my own for this evening. And that is, what are your goals for everyone listening in on this webinar? What would you like our viewers to take away from tonight? So Dr. Pedalillo, I'll go ahead and start with you.
Well, I hope the experience tonight was one that is educational, that you walk away knowing what your treatment options are if you have hip or knee arthritis, and you're more informed about what the treatment options include, whether it be non-surgical treatment options versus the surgical options. But I think the most important thing is that you realize that it's really a conversation between the patient and the physician, the orthopedic surgeon, to talk about what these options are and what the best option for any given patient is. And I often have patients ask me, how do I know when it's time for a joint replacement? but that's really not my decision. That's a shared decision-making process. So I hope everyone leaves tonight being more informed and really seeing the importance of having an ongoing conversation with your orthopedic surgeon regarding your options.
All right, thank you. Okay, and Dr. Starr, any final remarks from you?
Yeah, thank you very much. First of all, I want to thank everybody for coming and listening. Thank this community for supporting me for so many years. You know, we've done things out our way and the simple way and been here and, you know, helped the community for so many years and been a part of, you know, several great hospitals, which have now sort of morphed into part of the Jefferson Health System. So, you know, once again, thank you to our community far and wide that has, you know, been such an important part of our practice. We can't do it without you. As far as what we talked about tonight, I hope people leave this with a sense of optimism. It's easy to be pessimistic about, you know, the financial aspects of medicine and, you know, what may go on in the future. You know, fundamentally, there's an awful lot of good people. All these practitioners we mentioned, from the chiropractor to the acupuncturist to the, you know, the rehab doctor to the neurologist, everybody who works together with us to try to provide you the best care possible. That, you know, these people are all there for you. We're looking forward and we're excited. You know, some people really want to jump into the newer things like I do. Some people want to go a little more slowly, but you need both kind of persons to be part of your healthcare system. You know, we want you to feel like the Jefferson Health System, you know, can be a part of the solution for many of these problems, that we can provide a very comprehensive option for you. And we just want to we really want you to feel that, you know, maybe it would be too much to say that we want to be part of your family, but you know, we certainly want to be one of your friends to help you in making these decisions and, you know, coming to the right conclusion. We're not mad at you if you make a decision that might be difficult from the one we make, because honestly, patients do that every day. So I hope you enjoyed tonight. Have a wonderful evening and look forward to many other events like this, which you can learn about, you know, how you can possibly have the best life that we can help you to achieve.
Absolutely. Well, thank you for those closing remarks. That was great. Really appreciate your time this evening, both Dr. Petalillo and Dr. Starr. Thank you so much. A lot of great information was shared. I know I learned a ton. And thank you all to the audience for submitting and attending, submitting such great questions. The discussion was super insightful and interesting, so appreciate it. We will be posting an event survey, so you can let us know your thoughts. Any other specialties you would like to hear about, if you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please go ahead and fill out that last question in the event survey. Be sure to visit jeffersonhealth.org to make an appointment, stay up to date on upcoming events and webinars like this one and more. Be sure to also visit the Jefferson Health YouTube page to view more wellness webinar series events. We have various topics from back pain to robotic surgery to men's and women's health and much more. A recording of this event will also be sent to you so you can rewatch at your convenience. If there is anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a wonderful evening. Good night.